Guys, welcome back. Today we're going to talk about abdominal and urinary trauma in our patients. This lecture is fairly short. It's only 41 slides, so it shouldn't take that long. You see your competencies, uh, recognition and management of trauma, blunt versus penetrating. We're going to talk a minute about abdominal eviscerations. That's something you'll see on every test you ever take going forward. And we're going to discuss impaled object management and how that works. We're also going to talk about the pathophysiology, solid versus hard organs, blunt versus penetrating trauma, eviscerations, genitalia injuries, vaginal bleeding due to trauma, sexual assaults, vascular injury, and retroperitoneal injuries. That's where we really get into your kidneys in that retroperitoneal space. So the abdomen is the lower of the two major body cavities. The upper is the thoracic cavity, and the lower is the abdominal cavity. And then the smaller cavity at the very end inside of your pelvis, that is your pelvic cavity. So your abdomen starts at your diaphragm. Remember, your diaphragm separates the abdominal and the thoracic cavities, and it contains organs that make up the digestive and urinary systems. Injuries to the abdomen that go unrecognized will lead to traumatic death, the big one being bleeding, number two being sepsis. And we'll talk a little more about that as we get into it. So our abdomen is divided into four quadrants, and when you're documenting the abdomen, you document using the four quadrants. So you have the right upper, left upper, right lower, left lower quadrants. And when you palpate these quadrants, you want to palpate in a Z pattern. So if you start here, you want to go across, down, and across. Okay? If you start here, over, down, over. So you want to make a Z as you palpate the abdomen. And the umbilicus, the belly button, right here in the middle, that's where the quadrants meet. Here you have the diaphragm, and then here you have the pelvis. Okay? And the diaphragm is the absolute divide between the abdominal and the thoracic cavity. The pelvic cavity, sometimes you'll hear that referred to, is actually part of the abdominal cavity. The pelvic cavity contains some of your urinary system organs and some of your reproductive organs. Very rarely will you hear the term pelvic cavity used. Typically, we just kind of put that in with the abdomen. But if you ever see pelvic cavity, don't let that throw you off. That's basically the lower two quadrants of your abdomen makes up that pelvis cavity. So hollow organs are structures through which material passes. And hollow organs are mainly part of digestion. So we'll look at some of our hollow organs. That's your stomach filled with hydrochloric or different kinds of acid. That holds your food while it breaks down and digests. You have your gallbladder over here with your little bile duct going on, and that helps break down fats. It releases bile. Any of you have ever had gall problems, you know that fried chicken will inflame that because it starts to release bile. Then you have your intestines here. You have your large intestine, and that's what your fecal matter. That's how water is reabsorbed from your fecal matter. And then you have your small intestines, and that's where nutrients are absorbed. And then you have your bladder down here. Those are part of, that's a hollow organ. Your appendix right here, and remember, rebound tenderness at McBurney's point, which is the point between the pelvis and the belly button, which will be about right there. Rebound, so when you push down and let up, that's tenderness at McBurney's point, rebound tenderness, that's appendicitis. And these are your hollow organs. And the deal with the hollow organs is they don't really bleed a lot if they're injured, but they will cause massive sepsis from the food and things inside of them leaking out into your belly. Your solid organs, this is what kills you. You have your spleen right here. This is in your very left upper quadrant. The big thing with the spleen is the spleen and the liver are the two most commonly injured abdominal organs. But there's this thing called Kerr's sign. So if your patient has a spleen injury, they may also have left shoulder pain. And that's referred pain to the left shoulder from the spleen. That's called Kerr's sign. I think it's Khers. So anytime you have shoulder pain, that can be associated with abdominal trauma. You suspect a spleen injury, that's the classic sign, possibly a liver, but really, if you have the choice between liver and spleen, it's going to be the spleen. Your liver, now remember your abdominal quadrants are divided like um like that. So your liver is mainly in your right upper quadrant. There's a little piece over here in your left upper quadrant, but the largest part of your liver is in your right upper quadrant. Will kill you from bleeding to death. Your spleen will kill you from bleeding to death. Your kidneys are also full of blood. Your pancreas is a hollow organ. Injury to your pancreas can cause massive blood sugar shifts, and it can also cause some bleeding. Abdominal pain from penetration or rupture has a slow onset. Typically, by the time your patient starts showing abdominal pain, they're pretty far into the bleeding or injury process. And this is just a picture of kind of where your organs are and your great vessels. So your aorta, your vena cava, we're all familiar with those. And then we split off into your femoral veins and arteries. Okay? And any injury to those major vessels will cause a almost immediate death from just bleeding out in your abdomen. The urinary system controls the discharge of certain waste materials. So the kidneys, they filter materials and water, and that makes urea or urine, and then urine goes down into the bladder where it's held until you have to go to the bathroom, you pee it out. Your kidneys are solid because that's where your filtration takes place. Your ureters, bladder, and urethra are all hollow organs. Okay? The reproductive system controls the reproductive processes. So injuries to the abdomen can be both open or closed, blunt or penetrating trauma. Hemorrhage can occur with external or internal blood loss. External blood loss we pretty much can see. Problem is when we get that liver and spleen, we usually don't bleed out, we bleed in. And we bleed out within our abdomen. That blood ends up being trapped around our intestines and our abdomen. And your body can hold pretty much its entire blood volume in your abdomen. Your signs and symptoms will depend on volume of blood loss, rate which the body's losing blood. A small injury to the spleen or liver will bleed much slower than a large liver or spleen injury. And we assess our neurological and cardiovascular system for our signs of shock. If you do not know the signs of shock, compensated, decompensated, and irreversible, like the back of your hand, you really need to go back and learn those. Hypovolemia will lead to the patient experiencing agitation and confusion. A lot of times that's the first sign of hypovolemia, is anxiety or agitation and thirst. Then we get into anaerobic metabolism, which we start getting the lactic acid production. And that changes your oxyhemoglobin dissociation curve, and acidosis is really that killer in our shock patients. Injuries to hollow or solid organs can result in the spillage of their contents into the abdominal cavity. Hence, you get the sepsis, the infection, and the severe abdominal pain when those nerve endings get irritated. So peritonitis, and if you think about the peritoneum being the lining of the cavity, we have the parietal peritoneum, which lines the abdominal cavity, and then we have the visceral peritoneum, which covers the organs. And what happens is if those gastric juices spill out, you will have an intense inflammation of the linings of your abdominal cavity, and that will cause severe pain. Pneumoperitoneum is where you get a hollow organ that ruptures, and you get some air in the peritoneum. And we see this with abdominal surgery, rupture of abscesses, rupture of hollow organs. You get that air in the peritoneum, and that'll cause the patient problems. So here you see some bruising. Okay, that lets you know that there's been some blunt trauma to the abdomen. Could be from a deceleration injury. Remember that energy transformation can cause the aorta to tear, rupture a liver, break a spleen, those kind of things, and you can have some severe bleeding from that bruising. or redness is going to be your first sign that you have some kind of internal abdominal trauma. Crush injuries, you know, you get run over by a car, building falls on you, tree falls on you. You know, you have the injury, and then you have what happens from the prolonged pressure. Even with your crush injuries, you may have severe shearing forces that'll tear the aorta away from the heart. The ligamentum teres, that's from the liver. That's the artery that's the ligament at the liver, and it'll tear loose and pull the aorta or the portal vein or portal artery, and can cause some massive bleeding if you tear that. So, closed abdominal injuries, pain, tachycardia, decreased blood pressure, pale, cool, clammy skin. You may have a tender or rigid abdomen on assessment. Crepitus in the lower rib cage. Those lower ribs, you know, they reach out and they may get the liver or the spleen, depending on how hard the impact was. Curve sign, we talked about that shoulder pain. And bruising, anytime you see bruising, that lets you know that there's been some you know, intra-abdominal trauma. And this is bruising around the belly button. This is called Cullen's sign. And Cullen's sign is indicative of intra-abdominal hemorrhage. So if you see Cullen's sign, start thinking about internal bleeding. There's also one other sign, and it's Gray-Turner sign. And Gray-Turner sign is bruising over the flanks or on the sides, and that's a sign of intra-abdominal hemorrhage or you know, kidney hemorrhage. So abdominal injuries can result from seat belts. When you hit something fast enough, that seat belt will, you know, kind of tear into the body. It won't break the skin, but it'll kind of compress everything together. And you'll have liver lacerations, ruptured spleens, those kind of things. So you hit the steering wheel, you think about your chest, but, you know, what about your diaphragm, liver, spleen? You know, if you go up and over, those organs are part of that impact to the steering wheel and can sustain major damage. So, foreign object enters the abdomen and opens the peritoneal cavity to the outside. You know, these are your gunshots, your stab wounds, your penetrating trauma. There's a nice impaled object that we would want to stabilize in place. And then you have your evisceration. This is where your guts fall out. Sometimes you have large cuts or lacerations there, and your abdominal contents begin to spill out. So you may have bleeding, tachycardia, shock, distended abdomen from internal bleeding. The bleeding can be rapid and severe, and your patient can die, you know, fairly quickly from those injuries. And then you have the diaphragm. And remember, the diaphragm separates the abdominal and thoracic cavity. So what will happen is if you get a hole in your diaphragm, it ruptures, it tears, something like that. You know, you got your diaphragm. You get your little hole in it right here. Well, all of your guts from your abdomen will come up into that hole and end up in your chest. This can cause those organs to not have blood flow. So they can become ischemic and begin to die. You also talk about those organs being up in the chest. You can get you know, nasty fecal matter in your lungs, and patients may not be able to breathe. And then remember, in the respiratory cycle, you know, your diaphragm relaxes upward to push air out, and then it contracts downward to suck air in. And if you have an injury to that diaphragm, it's not going to contract and relax like it's supposed to. So you're going to have shortness of breath, difficulty breathing. You may have inadequate respirations. When you assess the abdomen, you know, you expose, inspect, palpate. Use your DCAT BTLS, and then look for tenderness, rigidity, distension, and swelling. A lot of times you can actually feel the area of those bleeds. So make sure you're doing a real good assessment. Injury to the kidneys. We see this a lot of times with our football players. Blunt trauma to the back especially will push the kidneys against the ribs and can cause them to fracture or lacerate and begin to bleed. These patients a lot of times will have pain when they breathe in. They also may have Gray-Turner sign, which is bleeding in the flanks. And you know, they may have a decreased urine output. But signs to the kidneys, you know, if it's penetrating, you know, if that didn't stop at the kidneys, you really want to start thinking liver and spleen, because the kidneys kind of sit right behind that liver and spleen. So make sure you're keeping in mind your angle, your cavitation, your trajectory of entry to kind of figure out what other organs may be damaged. Injury to the liver can be penetrating. That may cause a laceration, or it could be blunt, which would cause a liver fracture. No difference in laceration and fracture. Both of them are holes in the liver that cause a lot of bleeding. You got right-sided chest trauma, start thinking liver. Left-sided chest or abdominal trauma, start thinking spleen. Okay. A lot of times the spleen can rupture for medical reasons. Mononucleosis will cause the spleen to become enlarged. Also, sickle cell will cause an enlarged spleen. And spleen is the spleen is the graveyard for red blood cells, so it's going to be very vascular, and it's going to bleed a lot if it becomes injured. So you get blood in your abdominal cavity, so you'll have pain. You may have nausea, vomiting, and those signs of compensated shock. Injuries to the pancreas. That's going to cause vague pain that you really can't localize or put your fingers on, may radiate to the back. And it's going to lead to peritoneal irritation. So you're going to have a lot of abdominal pain after that injury. And injury into the intestines or stomach, you get really concerned about sepsis. But penetrating or blunt trauma can cause the stomach, the intestines, the gallbladder, any of those organs to rupture. And especially with appendicitis, we start seeing the rebound tenderness, which is where you palpate down, and then when you let up, the patient begins to experience pain. Trauma to the urinary bladder, we worry about the bladder rupturing, especially if it's full. Not going to have a lot of bleeding, but you're going to have urine that could spill all into the abdomen, which could lead to sepsis. The external male genitalia. External male and external female genitalia, we kind of treat the same. If it's bleeding, put direct pressure on it. We do not internally treat any of the genitalia. We do all of that external. Injuries to the testicle or scrotal sac may cause a loss of fertility. So if you get like a testicular torsion or something, you really want to get those patients to the hospital where they can be seen. And then your penis injuries can be blunt or penetrating, or from aggressive sexual behavior. And some people have like self-mutilation issues or sexual assault issues. Lorena Bobbitt, she had some issues, and she mutilated her husband's penis. And how would you treat that? You would just treat it like you would any other kind of wound. You can have what's called a fractured penis, and this is where when you're having intercourse and something happens, you get a lot of pressure to it, it will actually become crooked, almost like a bone breaking, but there's no bones. It's just some cartilage and a bunch of blood. But it can be very painful and also compromise blood flow to the penis, which will result in tissue death or loss of fertility. So we want to make sure we're rapidly transporting these patients to the hospital. Any bleeding or anything, we're going to do external control just like we would any other part of the body. Now the female genitalia, they have the uterus, the ovaries, fallopian tubes. They're rarely damaged just because they're positioned in the abdomen with that pelvis protecting them. But they can be damaged, so you want to kind of keep that in mind. And you want to look for your stabbings, your gunshot wounds, your blunt traumas. Signs and symptoms of shock with pregnant patients. Biggest thing with signs and symptoms of shock is a pregnant patient has a larger blood volume, so they're going to lose about 30% more blood, or 30% of their total volume, before they begin to show those signs and symptoms of shock. So by the time you start treating them, don't wait for the signs and symptoms to show up. Treat them early. Treat them aggressively. That way, those signs and symptoms, you're ahead of the game when they start to appear, because if you wait, your patient's going to decompensate and crash way too quickly. And we talked about injuries to the soft tissue around the genital area, and determine the possibility of pregnancy before test and treatment. Some medications can interfere with the fetus, so we want to be careful and avoid those. Always ask your patient, are you pregnant? And then you have your vascular injuries to the chest and to the abdomen, and these are caused by blunt trauma. You see this a lot with the aorta, and you get aorta dissection, aortic tear, transections, and those patients will almost immediately bleed to death. And then, the assessment findings will differ depending on where that is. You may have Cullen sign or Gray-Turner sign, or you may not have any signs at all, and You just have to suspect that there's some internal bleeding. We talked about the aortic aneurysms. That happens with a lot of blunt trauma patients. Patients present with rectal bleeding, and a lot of times you see these patients with sexual assault. You'll have torn tissue, a lot of bleeding. Um, we had a guy the other day, glass bottle into the rectum, massive bleeding because it broke. He almost died from shock because of that. Then you have colitis, ulcers of the digestive tract. All of those can cause internal bleeding, especially if they're exposed to some kind of trauma or some kind of energy change. Those can bleed pretty significant. So your patient assessment is basically the same. BSI, PPE, scene safe. Do I suspect abdominal or chest trauma because of my mechanism? Is this a penetrating or blunt trauma? And your patients may try to hide those injuries from you because that's a sensitive area. Same concept with every other patient, DCAT, BTLS, airway, breathing, circulation. Remember your, excavating hemorrhage. And look for hemoperitoneum. That's blood in the abdomen. Tenderness, rigidity, distension, swelling, bruising, Cullen sign, Gray Turner sign. Those are the signs you're looking for. Get your history. Find out what happened. Abdominal complaints always get a question about the bowel movement. A lot of times abdominal pain is just a fecal impaction, but sometimes it's bleeding. No way for us to tell in the field what's going on. Any patient exhibiting abdominal pain is aggressively treated as if they have a GI bleed. Get your secondary assessment. Do your trending with your vital signs. Focus on your isolated injuries. Do your physical exam. You're looking for contusions, abrasions, or hematuria, which is blood in the urine. Those are all signs of intra-abdominal trauma. And assess the patient for pain. You want to get a pain scale on them. Reassess your patient every 5 minutes for abdominal trauma because those patients will decompensate quick. Communicate the mechanism of injury and the injuries to the hospital. The treatment for most of abdominal trauma is surgery. So, most abdominal issues have to be fixed by a surgeon. So I want to get them to that surgeon. Spinal immobilization if needed. These patients always get high flow oxygen because of the risk of bleeding. Use your mask trousers to stabilize the pelvis if you need to. And most abdominal trauma requires rapid transport to the most appropriate facility, which is probably going to be a facility with a surgeon. Patients may have a combination of injuries. Check for diaphragmatic injury. Monitor the patient's vital signs. Basically do your assessment like you would any other patient. We want 2 large bore IVs for blood replacement. So we got our oxygen. We got our 2 large bore IVs. If the patient has an object that has penetrated the abdomen, remember the injuries inside are going to be way worse than the injuries on the outside. So abdominal evisceration. This is where the intestines come out. Real simple. Put a sterile, moist dressing. So wet you a dressing with some normal saline. Put that over it, and then put a piece of plastic over it to make it occlusive. That's just a picture of what you do. There's your dressing going on, your wet dressing going on. Put a piece of plastic to keep air from getting in there. And now you have just fixed your abdominal evisceration. So your kidneys, these are signs of shock. Not a lot you can do to treat them. You just have to treat the signs of shock, but they will bleed. And kidneys will also cause the patient to have renal failure, which will cause them to go into have to have dialysis. And then you have your urinary bladder. This usually can rupture. You get urine in the abdominal cavity, can cause sepsis, a lot of abdominal pain. External genitalia, injuries to the external male genitalia, they're going to be very, very painful. There's also arteries and veins that feed the penis, so you may have some serious bleeding. And control that with direct pressure. If there's an avulsion to the penis, put it back in place and cover it up. If it's completely avulsed, take that avulsed skin to the hospital. They may be able to reattach it. And do not manipulate any impaled object inside of the body unless it's the cheek or chest, and we'll talk about those in just a few minutes. You can take an object out of the cheek if it affects the airway, and you can remove an object from the chest if it hinders CPR. All the other objects we're going to stabilize in place and not move them because they'll cause serious internal damage. Female genitalia, we do external exams and treat external injuries. We don't do anything for the inside of the female genitalia. And we treat external bleeding by just holding pressure or putting some kind of sanitary pad there. If the bleeding is heavy, we'll do some local compression to the outside. Typically, we're good with that sanitary pad. If there's a foreign body there, leave it in place. Do not mess with it. And any part of the body that has contusions or swelling would elevate